We're going to talk about dysrhythmias. Here are your objectives related to dysrhythmias. When discussing dysrhythmias, you're going to hear me use the terms symptomatic and unstable. And it's very important that you understand and you can distinguish the differences between these two terms because they are not interchangeable. Symptomatic means the patient is having physical symptoms. I want you to think about another state of hypoperfusion, such as shock. What happens in shock? The patient is symptomatic at first when they are compensating, but they are still hemodynamically stable. I want you to think of a patient being unstable as a patient decompensating. Yes, they're going to be symptomatic, but there's also going to be that presence of hemodynamic instability. Unstable is going to be focused on the severity or volatility of that situation. Is it life threatening? If action is not performed now, are there going to be life threatening outcomes? So just remember the difference between symptomatic and unstable goes back to, is that patient hemodynamically stable? Are they perfusing their organs? Are they hypotensive? Go back to the hemodynamics. The sinus dysrhythmias I will be discussing may include sinus arrhythmia, sinus tachycardia, sinus bradycardia, AV blocks, and sick sinus syndrome. But I want you to know that I will only test you on sinus tach, Brady, or a third degree heart block. Like with sinus bradycardia and sinus tachycardia, our sinus arrhythmia is going to be a dysrhythmia that occurs within the SA node. But instead of it being related to the rate of which the SA node is firing, this is going to have to deal with the regularity. You will notice that when you march it out, sinus arrhythmia is going to have an irregular rhythm. But you're also going to notice that there's a bit of a pattern to it. And it's because most of the time it's going to be related to ventilation. Um, what happens is the heart rate is going to frequently increase with inspiration and decrease with expiration. And this is going to be more common in children. And it can also be related to pathogenic causes such as heart disease, valvular disease, and it can also be drug related. But most of the time, it's benign, seen in younger patient populations, and it's not going to require any treatment. Sinus tachycardia can be a normal response to stressors of the body, such as exercise, pain, stress, fever, or it can be a manifestation of a pathological process, such as heart failure. It could be the result of certain medications, such as epinephrine, atropine. It could result from other things, such as caffeine, nicotine, and drugs like cocaine. Or it can be caused by other conditions, such as anemia, respiratory distress, pulmonary embolus, sepsis, and hyperthyroidism. So, how do we treat tachycardia? Well, that all depends. Is the patient symptomatic? For asymptomatic tachycardia, that's usually going to be benign. It's going to be caused by something such as exercise, caffeine. So, it's going to require no treatment because it is not causing any physical symptoms to the patient, and they are able to compensate for this completely on their own. Now, symptomatic tachycardia may require treatment. Symptomatic tachycardia could be tachycardia that is accompanied by things such as syncope, blurred vision, chest pain, nervousness, anxiety, and things of that nature. But it is very important that you treat the patient and not the number. Let's do a quick scenario. Let's say I come into the emergency room. My heart rate is 140. I have a little bit of nervousness. All my other vitals are pretty stable at this time. The provider says, hey, let's get that heart rate down. I don't like that 140 heart rate. So he orders 5 of metoprolol and you give it. What if I was compensating for something? What if I was in shock and my heart rate increased to help maintain that cardiac output? And now you give me metoprolol and you take away the one thing that is allowing me to compensate? Guess what's going to happen? Your patient's going to bottom out. They're going to become hemodynamically unstable. Now, if a patient is symptomatic, I want you to treat that underlying cause. Remember, treat the patient, not the number. Is the patient fluid volume overloaded? If so, maybe we need to give diuretics. Is the patient in pain? Treat the pain. Does the patient have a fever? Give the patient an antipyretic. Is the patient in pain? Treat the pain. Is the patient in shock? Treat that underlying cause of that shock. Don't just treat the number. Now, if a patient is symptomatic, next you need to ask yourself, are they hemodynamically stable? Often with sinus tachycardia, they are going to be stable. And rarely do you ever have to resort to invasive methods such as synchronized cardioversion. But if a patient who is symptomatic becomes unstable in any type of tachyarrhythmia, you need to immediately shock them. Remember that. But you're not going to shock a symptomatic patient that is stable. Just like with sinus tachycardia, sinus bradycardia can be a manifestation of a disease process such as hypothyroidism, hypoglycemia. It can result from things such as head trauma or spinal cord injuries, increased intracranial pressure. It can occur from medications that slow down your heart rate, such as beta blockers, calcium channel blockers, digoxin, and other antiarrhythmics. It can occur from hypothermia. And sometimes it's just going to be a physiological consequence of decreased metabolic demand. For example, when we are in our deep sleep, a lot of people will become bradycardic because we don't have that much demand. And remember, athletes can also be bradycardic at baseline because their heart is healthy and it doesn't have to work at the same degree as, let's say, my heart, because I'm definitely not athletic. So when a patient has bradycardia, you're going to ask yourself, are they symptomatic? Are they having that signs of syncope, chest pain, shortness of breath? Are they diaphoretic? Like, what's going on? What does the patient look like? So how do we treat sinus bradycardia? It's very similar to sinus tachycardia. That all depends. If the patient is symptomatic, it's not going to require treatment because likely it is caused by something benign. If a patient is symptomatic, the drug of choice is atropine. However, I want you to think about the underlying cause of the bradycardia. What if the patient's hypothermic? You definitely want to start warming them up. Let's say they take calcium channel blockers or beta blockers and there's an expected overdose of these medications. It would be more appropriate to treat beta blockers with the reversal agent, which is glucagon, or calcium channels with the reversal agent, which is going to be calcium or glucagon. That would be treating the underlying cause. Other medications we can use for symptomatic bradycardia, if they're not responsive to atropine, could be dopamine or epinephrine. Now, if a patient is symptomatic, ask yourself, are they stable? If they're unstable and they're unresponsive to atropine, that's where you need to become more invasive and you need to place the patient on the transcutaneous pacemaker. You're going to place the pads on the patient and you are going to begin pacing them. Heart blocks can be very intimidating if you don't understand what's going on. But once you get the hang of it, you'll realize they're actually pretty easy to identify and to differentiate from one another. So, if the R is far from the P, then you have a first degree. So a first degree heart block is just a PR interval that is greater than 0.20. So all it's saying is it's taking the atria longer to send that impulse to the ventricles. Longer, 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 drop, then you have a winky block. This is a second degree type 1 heart block. And what happens is your PR interval is going to get progressively longer with each beat. And then out of nowhere, you're going to drop a QRS complex. With your Movitz type 2, if the P's don't go through, then you have the Movitz type 2. And what's going on here is you're going to have a normal PR interval. Normal PR interval, and then out of nowhere, you're just going to drop a QRS complex. And if your P's don't agree, then you have a third degree. With your third degree heart block, there is no association between what the atria and the ventricles are doing. So you're going to see that they're both going to be doing their own thing. But you'll see that you can march out your ventricles, but you'll have like a P wave, you might have two P waves, and then a QRS. They're just all doing their own thing. So with our first degree heart block, most of the time, this is going to be asymptomatic and benign. And this is just a PR interval that is greater than 0.20 seconds. So what's going on is the impulse is taking a little longer to go from the atria to the ventricles. And you'll see this sometimes as a normal variation in patients, or you'll see it in well-trained athletes. But it's important to recognize that it can also be pathologic. You may see it in patients who have electrolyte imbalances. You can also see it in patients who take certain medications, such as your beta blockers or your calcium channel blockers. But again, this usually isn't going to warrant any type of change in regimen for medications. We just watch it because we kind of expect that beta blockers may lead to this. So with our second degree type 1 or our winky block, remember your PR interval gets longer, longer, longer drop, then you have a winky block. This is usually going to be asymptomatic as well, and it can be caused by medications, electrolyte imbalances, heart disease, valvular diseases, but occasionally patients may experience dizziness or fainting, and that's when we need to make sure that we are treating it because it's all about the symptoms. Now, our second degree type 2 or our Movitz, that's where we have the PR intervals normal, 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 and then suddenly we just drop a QRS. This is always pathological, and it's going to be caused by things such as cardiac injury, Lyme disease, medications, valvular pathologies, and whatnot. And for this, patients are often going to be symptomatic. And the reason that we need to watch this is because this can be a precursor to a third degree heart block, which is a medical emergency. So a lot of times, if a patient has a Movitz type 2, you'll see that a permanent pacemaker will be placed, and that is to prevent that third degree heart block from arising. Now, a third degree heart block is a complete heart block. So the atria and ventricles are dissociated from each other. They're both doing their own thing. So think about it. Your atria is filling when it wants to, and your ventricles are going to be filling. There's no unity. So you're going to have a lot less blood that is going to enter the ventricles, which is going to significantly reduce cardiac output. I wanted to spend a little bit more time with the third degree heart block because this is a medical emergency. With the third degree heart block, we know it's a complete atrioventricular block. So the electrical signal from the atria is completely blocked from reaching those ventricles. And this is going to result in the atria and ventricles beating independently. And it's going to cause a very slow and inefficient heart rate. And patients will likely have severe symptoms such as dizziness, fatigue, shortness of breath, and chest pain. And this is going to lead to reduced cardiac output, reduced perfusion, and the treatment for this is going to be a permanent pacemaker to prevent patients from going into this block.
A little bit about sick sinus syndrome. This is a pathological condition that results from dysfunction of that SA node, and it usually is going to result from direct injury to that sinus tissue or those pacemaker cells within the SA node. This can occur through fibrotic changes associated with aging or through cardiotoxic drugs such as DIG, calcium channel blockers, and beta blockers. Or this condition may be idiopathic in nature. Now, patients' heart rates are going to, and rhythms are going to fluctuate. Patients may go through sinus tach to AFib to aflutter, then suddenly they are experiencing bradycardia, then they may go into atrial tach, and then they may have episodes of sinus pauses or sinus arrest, which you can see on this EKG here. And that can ultimately lead to sudden cardiac death. Now, when patients' heart rhythms and rates are fluctuating like this can significantly reduce their cardiac output. So patients may develop syncope, lightheadedness, dizziness, and they may even have episodes of fainting. They may have signs of decreased perfusion, and they may experience things such as chest pains, palpitations, headache, and fatigue. And the fluctuation in heart rate and rhythm may often be triggered by certain stressors such as exercise, fever, sickness, and psychological stress. It is usually diagnosed with the table tilt test. Patients may wear that Hoyer monitor at home. And obviously they may have to take medication such as atropine to bring that heart rate up. And since they may go into a flutter fib, they may need to take anticoagulants to prevent the development of clots within that atria. Treatment often is going to involve a pacemaker ICD combo, just because look at those sinus arrests. Look at that. That's scary. The patient goes completely flat. And you want to make sure that we can keep the patient's heart rhythm at an appropriate number, so we would do the pacemaker component. And if they go into a tachyarrhythmia such as VTach, we want to make sure that the ICD mechanism can shock them and hope that the SA node will take back over. I know you've learned about pacemakers before, so this is just going to be a quick review. Pacemakers may be temporary or permanent. Patients who don't require long-term pacing may just have a temporary pacemaker. Like patients who have had beta blocker toxicity. We want to give them that glucagon, but then we may apply the transcutaneous pacing. And once, all of that medication is out of their system, they may not require further pacing. Likely they won't. Or we will use the temporary pacing until the permanent pacemaker is placed for patients who require permanent pacing. Temporary pacing can be transcutaneous, that's where we place the pads over the skin, or it can be transvenous, and that is where it is going to be placed into one of your central veins, and patients are going to require hospitalization in the ICU for this. That is the only place where we can have this type of device. Temporary can also be epicardial. That's going to be your post-CABG patients. Now, your permanent pacemakers, you can have them either at a fixed rate to where that the pacemaker is going to fire every time at a certain interval, which is set on the pacemaker, or they can be on-demand pacemakers, and those are going to be more commonly utilized. For example, if we set the pacemaker to 60, if the patient's heart rate maintains over 60, that pacemaker is not going to fire. However, if the patient is not sustaining a heart rate over 60, that pacemaker will fire in order to sustain that heart rate. And then you can have the pacemaker defibrillator combinations, and that's going to have that ICD in it as well. Generally, pacemakers are going to be used for patients who experience bradyarrhythmias because we want to maintain that heart rate. And your AICDs are going to be for those patients who experience those ventricular arrhythmias, like your VTAC and your VFib, because what it's going to do is shock the heart in order to try to get that SA node to take back over its default pacemaker role. Now, some patients are just going to require atrial pacing, and that's when they're going to have an interruption to the conduction system within the atria. You will see the pacemaker spike before that P wave, so before that atrial depolarization. Now, some patients are going to require ventricular pacing, and that's going to be when they are experiencing a problem within that ventricular conduction. So you will see the pacemaker spike before the QRS. And some patients are going to be atrial and ventricular paced. That's called dual paced. You will see the pacemaker spike before the P wave and before the QRS. Two common problems or complications that can arise with pacemakers are going to be failure to sense and failure to capture. With failure to sense, the heart is beating properly, but the pacemaker is not sensing that, and it is continuing to fire when it is not needed. Now, with your failure to capture, this is very serious. So the heart is not beating appropriately, the pacer spike is being fired, but the heart is not responding. So that needs to be reported to the provider immediately, because the patient can go into a very severe bradyarrhythmia or cardiac arrest. Now, let's look into some nursing considerations related to pacemakers. Obviously, when we place a transcutaneous pacemaker on a patient, and we have to use it. It is going to be uncomfortable. It is going to deliver a shock. So this is going to be uncomfortable for the patient. So we may want to give them a mild analgesia or sedative if it's not a life-threatening emergency. You want to monitor for signs of improvement, and you want to inspect the skin for thermal burns with that transcutaneous pacing, because we are delivering electricity. And remember, electrical burns can happen and they can be pretty serious. Now, when we are applying that external pads, we need to make sure that the area is clean, that we shave the patient's chest, and that we apply the appropriate skin prep to make sure that this device is adhered properly and so that it can work properly. Now, remember, when we are delivering a shock, we need to be all clear. Don't sit there and have your hand on the patient or on the bed. Now, with our permanent pacemakers, their patients are going to have a limb restriction depending on the area that the pacemaker has been placed in that chest. For about 2 weeks, they need to not lift heavy objects. Don't go in and join a hockey team, for 2 months. I mean, I wouldn't join a hockey team ever if I had a pacemaker, AICD, but whatever. You want to make sure that they're not heavy lifting for a few months, that they wear loose fitting clothing, no restrictive clothing. They need to shower only until that incision is healed. They need to check their pulse regularly and always carry a device card, so if something happens, first responders know what they're working with. And they need to report signs of decreased cardiac output immediately. This could mean device malfunction. That could be dizziness, fainting, fatigue, palpitations, weakness. And they need to report ongoing hiccups, because that could mean that the diaphragm is being paced, not the heart. And we need to fix that. Now, when it comes to patient education, this is a very important part of nursing. So you need to let patients know what to expect. Now, patients may have a change in their level of consciousness prior to a shock. When a patient is receiving a shock, anyone who is touching them may feel that shock, but it won't cause any harm. Shocks may feel like a blow to the chest. They need to follow recommendations for household magnetic interference. It used to be that an MRI was completely out of question if you had a AICD pacemaker. However, some of the newer devices are MRI compatible, so it's important to know that. At airports, they need to notify TCA, hey, I have a pacemaker. Don't put your wand at me. TCA can be kind of aggressive. So they are going to need to be manually searched and not go through those devices. And batteries can last anywhere from 5 to 15 years normally.
Next, I'm going to talk to you a little bit about atrial dysrhythmias, or abnormal heart rhythms that originate in the atria. And these are going to occur when the electrical impulses that control atrial contraction become either irregular or disorganized. And there are various different types of atrial dysrhythmias, including PACs, supraventricular tachycardia, AFib, a flutter, wandering atrial pacemaker. And so I'll talk to you about some of these. Premature atrial contractions, or PACs, are usually not serious as far as atrial dysrhythmias go. However, they can be one of the first signs that a patient is going to convert into a more serious atrial dysrhythmia, such as a flutter or AFib. And so they should be monitored. AFib is very serious and it's very common. So you'll see a lot of times before a patient transitions into AFib, you'll see that they frequently have frequent PACs. And PACs can also be caused by things such as caffeine, alcohol, nicotine, hypervolemia, electrolyte imbalances such as hypokalemia, anxiety, atrial ischemia, injury or infarction. And let's look at this EKG here. And when we're looking for a PAC, we just need to first try to find that underlying rhythm. Let's look at what's going on with this EKG. If we look, all of our QRSs march out. We have a P wave before every QRS. Our PR interval is normal. Our QRS is less than 0.12. The only thing is there's this one beat that just doesn't march out. And we see that that beat has a normal QRS, so I know it's not a PVC, and it has an upright P wave, so I know that it has to be a premature atrial contraction. So what I would call this rhythm is sinus rhythm with a PAC. Supraventricular tachycardia, or SVT, is a type of narrow complex tachycardia that occurs above the ventricles, hence the name supraventricular tachycardia. And with this type of tachycardia, you're going to have a narrow QRS or a normal QRS. It's not going to look wide and bizarre. So we know that the problem isn't in the ventricles. And we will notice that with SVT that we can't quite see what's going on with the P wave. And because of this, our goal is ultimately to slow it down because SVT could be one of many rhythms. We just don't know because we can't see that P wave because we're going too fast. SVT is usually going to be between about 150 to 220 beats per minute, although it can be less or more. But we just don't know what the P waves are doing. I can't see what's going on. I have no idea what this rhythm is. I just know that my QRS is normal. The patient may be in a flutter, they may be in AFib, they could be in atrial tachycardia, junctional tachycardia. We just know that our QRS is normal. When treating SVT, it's important to understand that we don't know what that underlying rhythm is and that we follow the decision model of least restrictive versus invasive and stable versus unstable. Most of the time when a patient's in SVT, they are going to be symptomatic. They may have something such as chest pain, syncope, fatigue, dizziness, palpitations. But the question you need to ask yourself, are they stable? Is my patient showing signs of rapid deterioration? Are they hypotensive? Are they showing signs of decompensation? If a patient is in SVT and they are symptomatic but stable, we first want to try vagal maneuvers because that can slow down the heart rate. If that doesn't work, we may try a medication such as adenosine. And adenosine is a chemical cardioverter. And what adenosine is going to do is it's going to slow down the heart rate enough for us to see what that underlying rhythm is because we treat AFib different than we treat, let's say SVT was caused by sinus tachycardia, which is rare, but we treat both of those rhythms differently. And you may see other medications given, such as metoprolol to slow down that heart rate. You may see other medications like amiodarone. But I want you to know that adenosine is going to be a primary medication. And this can actually stop your heart completely. and you can have a brief period of asystole. Because what's happening is it's resetting the heart so that the SA node can hopefully take back over. And anytime you push adenosine, a provider has to be in the room. You must have crash carts set up and emergency equipment on standby. And it is important that you push it rapidly because it has a very, very short half life. So, a lot of times you will push adenosine with a stopcock. Now, if a patient is unstable, let's say, hey, I can look at my patient, I can tell they are rapidly declining, that they are decompensating, they are hypotensive, they look like they are not perfusing. Then I don't care about least restrictive versus invasive. Then we go straight for stable versus unstable. And if your patient is unstable, you're going to immediately perform synchronized cardioversion. Obviously, ideally, you want to medicate them before this, and that's in the optimal situation, but sometimes you don't have time for that. So just remember with our SVT, we're going to go with stable SVT. We're going to do least restrictive methods such as vagal maneuvers, medications such as adenosine, amiodarone, metoprolol. And then if the patient's unstable, we drop everything we're doing, any medication, and we go straight to synchronized cardioversion. As I said, SVT is a term we use to describe a type of tachycardia that's occurring above the ventricles where the P wave, we can't identify what's going on. So we use this umbrella term to describe until we can slow that heart rate down to figure out what rhythm it actually is. Well, atrial tachycardia is just one of the many umbrella terms that fall under SVT. And with atrial tachycardia, most of the time it's going to be paroxysmal in nature, meaning it's going to come in small fits and then it'll go away. And a lot of times patients may be asymptomatic depending on how long they are in ATAC, but it's usually going to be caused following open heart surgery, certain medications, or drugs. But again, it's an SVT, so I want you to think of least invasive versus stable versus unstable when treating this. AFib is the most common dysrhythmia in the United States. It's estimated that anywhere between 5 million to 10 million Americans live in a state of chronic and or permanent AFib. And we know normally when the SA node fires, it fires in a very organized manner, right? It goes the SA node to the AV node, down into the bundle of His Purkinje fibers, causing the ventricles to contract. We know that it's organized and efficient. But with AFib, what's going on is you're going to have rapid, chaotic, and uncoordinated electrical activity coming from various parts of the atrium. And this is going to cause the atria to quiver. So you're going to lose that atrial kick or that atrial systole. Remember that extra bit of blood that is pumped before ventricular systole to allow the ventricles to have even more cardiac output? Well, what's going to happen is a patient in AFib loses that atrial kick. So they can lose up to about 30% of their cardiac output. However, what does the body like to do? It compensates. Remember, we are constantly compensating. And as I said, 5 to 10 million Americans live in a state of chronic or permanent AFib, so we know that it's not necessarily immediately life-threatening. However, if a patient lives in chronic or permanent AFib, they're going to be 5 to 7 times more likely to have a stroke. And I want you to think about why. We know that when the atria quiver, it's going to cause blood to pool. And when blood pools, what does it like to do? Coagulate, clot. And if it leaves that left ventricle, it's going to go right up there into those small vessels into the brain, causing an embolotic stroke. Things that cause atrial fibrillation are various disease processes such as hypertension, MI, diabetes, drug use, heart failure. The typical disease processes that we see over and over. Some patients who are in AFib are going to be asymptomatic, especially if their ventricular rate is controlled. With AFib, your atrial rate can be beating up to 300 to 600 times a minute because that atria is quivering. But as long as the ventricles are controlled, it's usually not immediately life threatening. However, patients who have AFib are going to be at greater risk for certain disease processes such as stroke, pulmonary embolism, and whatnot. There are various types of atrial fibrillation, and it's important to understand that because treatment is going to differ depending on how long a patient is in AFib. Most of the time, when a patient initially goes into AFib, it's going to be paroxysmal. So it's just going to occur in small episodes, and gradually these episodes will last longer. Then a patient may go into chronic or persistent AFib, and that's going to be AFib that is sustained more than 7 days. And then patients may have AFib that lasts for longer periods, years at a time. And then we call permanent AFib for a decision that has been made between the physician and the patient that they are no longer trying to restore normal sinus rhythm, but they are going to focus on supportive care for that AFib. So they've tried various different treatments, and regardless, the patient keeps transitioning and staying in AFib. So now the goal is no longer rhythm control. It's going to be things such as rate control and anticoagulation. The treatment options for AFib are going to differ depending on what type of AFib the patient is in and if the patient is stable or unstable. For example, patients who are in paroxysmal and chronic AFib, elective cardioversion may be warranted. And if the AFib has occurred more than 48 hours onset, a TEE or anticoagulation prior to cardioverting the patient is warranted because remember, when the atria is quivering, blood is pooling, and the longer a patient stays in AFib, the more chance they have of developing clots. And a patient is actually at most risk for dropping that clot and it embolizing when normal rhythm is restored. So, in situations that aren't an emergency, if cardioversion is warranted, just make sure if it's greater than 48 hours, a TEE anticoagulation is performed. We want to give a mild sedative if it's not emergent because it's not going to be comfortable. You want to charge anywhere from 120 to 200 joules, all clear. Now, for our patients who are in chronic AFib, semi-permanent, or permanent AFib, the goal is likely going to be more of rate control. When the atria are quivering, the ventricles usually are going to fire faster in an attempt to compensate. But what's really happening is that it's causing more misalignment and actually further decreasing cardiac output. So the long-standing goals of that chronic and permanent AFib are going to be rate control. You'll see patients are given beta blockers such as metoprolol. You'll see calcium channel blockers. You'll see some patients may be on digoxin. Or you may see rhythm control. These are going to be drugs that we give to try to put the patient into sinus rhythm again. And this could be things such as amiodarone, lidocaine, calcium channel blockers. It just all depends on the situation. But we know that ultimately our patients with that long-standing AFib, our goal is going to be rate control and anticoagulation to prevent stroke and PE. We know with AFib, our atria are firing chaotically and they can be beating up to 600 times a minute, making us lose a significant amount of our cardiac output. But again, where do we get most of our cardiac output from? Those big ventricles. So, as long as we keep the ventricular rate under control, most of the time a patient can compensate enough to sustain cardiac output. So, when a patient's in AFib and it's firing and chaotic, what the ventricles try to do to compensate for that is to beat faster to help that cardiac output stay maintained. However, what's going on is you have that rapid firing of the atria and your ventricles are going so fast, and now they don't have time to adequately fill as they're pumping. So you're going to lose a drastic amount of cardiac output. And this can be a reoccurrent problem with patients who have chronic and persistent AFib. You'll see that they'll go into periods of RVR, and ultimately, you'll see that part of AFib management is going to be rate control drugs such as metoprolol, cardizem. But when treating AFib RVR, you need to think of one thing. A, is the patient symptomatic? If it's a very short burst or proximal event, they may not be. Or they may have symptoms such as syncope, chest pain, shortness of breath. But I want you to ask yourself, okay, they're symptomatic, but are they stable? Is the patient hypotensive? Are they showing signs of imminent decline? If not, focus on that rate control. You could begin PO meds, and as you wait for them to start to work, you could start IV medications such as amiodarone, digoxin, or whatnot, cardizem, metoprolol. Now, if the patient is unstable, let's say they look like they're decompensating, they become hypotensive, their blood pressure drops drastically. You can feel that they are rapidly declining. Then ultimately, forget the meds, drop all the meds, no meds. You need to cardiovert this patient immediately. Now, remember, we ideally want to give a patient sedation because cardioversion is not comfortable. It's a big old shock. However, there's going to be certain situations where pain is not the priority. Pain or death? Which one will kill you first? Death, right? Exactly. And remember how I said that patients who are in AFib longer than 48 hours, it's usually best to do a TEE or make sure the patient's been on anticoagulation? Well, in this situation, let's say the patient were in AFib chronically and their ventricular rate had been controlled. Now, an acute exacerbation of, let's say, their COPD has caused an episode of AFib RVR. And let's say anticoagulation is contraindicated in this patient. So, but they're in AFib RVR and they're rapidly declining. Unfortunately, they do have a risk of an embolization when you cardiovert them, but ultimately, what is the biggest risk here? What will kill them first? So you will need to look at the risk versus the benefit, and ultimately, if they're unstable, it's cardioversion, whether or not there's been anticoagulation. Let's interpret this rhythm. First, we want to count that rate. We want to count the number of R waves or QRS complexes. And we count that there are 9. Now we want to look at that rhythm. Is it regular or is it irregular? Ooh, it's very irregular and chaotic. Now let's look at the P waves. What P waves? All I see are these chaotic fibrillatory waves, meaning that the atria could be beating up to 600 times a minute. Those are not discernible. They're chaotic. So I'm going to say none. And now we need to look at the PR interval. Well, if you don't have a P wave, you can't have a PR interval, can you? No. So now let's look at that QRS. And we can see that the QRS looks normal. So because of this and those fibrillatory waves and the normal QRS, I know that I must be an AFib.
Let's look at A flutter. A flutter is pretty easily to discern, and you're not required to know how to interpret this rhythm for this course, but you will see it in the clinical setting. So let's talk about it. You will notice that it's much more organized than your AFib, and it may actually be regular or irregularly regular, because you will notice that these sawtooth waves that are where your P wave should be generally follow a pattern. For example, you may have a 2-to-1 conduction, and that is where you're going to have 2 sawtooths for every QRS. You may have a 3-to-1, 3 sawtooths for every QRS, and a 4-to-1. And occasionally patients can kind of go into a variable AV conduction, which you don't see as often. Now, the higher that your conduction ratio is, for example, a 4-to-1 is going to have a much higher atrial rate than a 2-to-1. And your atrial rate is generally anywhere from 250 to 300 beats per minute. And that's okay as long as your ventricular rate is going to be under 100. You don't want that rapid firing of that ventricular rate, because when that happens, you don't have any cardiac output. And treatment is going to be very similar to that of AFib. If a patient is stable, we are going to work on our rate control and our anticoagulation. But when a patient's unstable, we need to do that synchronized cardioversion.
Remember, with our bradyarrhythmias, we go from least invasive, such as giving medications such as atropine. And if that doesn't work, or if the patient becomes unstable, we may need to pace them, which is much more invasive. Well, the same thing is for tachyarrhythmias. Obviously, if a patient is symptomatic but stable, we're going to go with least restrictive, such as medication, vagal maneuvers, things of that sort. Let's treat the underlying cause. Let's give an rhythm control medication or a rate control medication. However, if a patient has persistent or long standing tachyarrhythmias, they're likely going to become unstable. And as soon as the patient becomes unstable, you forget least restrictive versus invasive, and you think, what is going to save my patient's life? So, anytime a patient becomes unstable, immediately you need to shock them. It's not about giving medications anymore. You need to reset that heart. So, hopefully, the SA node will take back over. And you'll start off with smaller burst of shock, and then you'll continue to go up. It's important, obviously, if you can, you want to medicate the patient prior to shocking them. You want to tell them what to expect, and you want to be supportive. But ultimately, a lot of times, where I'll say most of the time, where we've started cardioversion, it's not been elective. The only time I've been able to give medications such as fentanyl or Versed has been in situations where it's been elected or planned. But a lot of times it's very emergent, and you need to get those pads on that patient and shock them right now.
Let's talk about wandering atrial pacemaker. This is actually a really cool rhythm. You're not required to interpret it from this course, but you will see it in the clinical setting. So with wandering pacemaker, your default pacemaker site is going to shift between your SA node and your AV node. So you're going to be going like in between a sinus and a junctional rhythm. And what's going on is these sites are actually competing to become that natural pacemaker. So you will see a variety of different P waves. And in order for a rhythm to be considered atrial pacemaker, you have to have at least three different types of P waves. They may be upright, inverted, flat, they may be in the QRS, after the QRS. You may notice some of them are peaked. It's definitely very interesting. I want you to kind of look at this rhythm and see if you can see that variation in those P waves. And this is generally going to be an irregular rhythm, and the heart rate will be under 100. And your QRS is generally normal. Now, we are going to talk a little bit about your junctional rhythms. Now, you're not going to be required to interpret them for this course. However, you will see them frequently in the clinical setting, and it's important you understand what is going on. So, they are going to result from the SA node failing to fire. And because of this, the AV node is going to pick up the work and become that default pacemaker. And this can actually change the way electricity is being conducted through the heart. Normally, your electricity is going to go from a positive to negative deflection, which is why you have upright P waves in your sinus rhythm. Now, this can actually reverse in your junctional rhythms, and because of this, you can have inverted P waves. You may also have what appears to be absent P waves, and that is just because the P waves are going to be inside that QRS and you can't see them. You may also notice with junctional rhythms that you have a P wave after your QRS. And generally, your PRI is going to be normal unless the patient develops a heart block in this rhythm, and your QRS is going to be normal as well. You have various types of junctional rhythms, and that is going to be based on the heart rate. Your junctional escape is generally going to be 40 to 60 beats per minute. Your accelerated junctional is 60 to 100, and your junctional tachycardia is going to be any rate over 100. And obviously, you are going to want to treat the junctional escape if the patient becomes symptomatic.
That is all for this presentation. Next, we are going to talk about ventricular dysrhythmias. Yay! There's more. And then after that, there's more.